Good morning, and thank you for joining us as we discuss the changes CMS proposed to the Office Evaluation and Management Coding, or E&M codes, to reduce unnecessary administrative burden on clinicians, allowing them to focus on their primary mission, improving their patients' health outcomes. At CMS, following the leadership of President Trump's Cut the Red Tape initiative, we launched our Patients Over Paperwork initiative. As part of this initiative, my team and I spent the past year traveling the country talking to clinicians from different care settings. And one thing we heard time and time again was that time spent on paperwork is time away from patients. We heard frustration from clinicians and too many stories about provider burnout. During my travels, it became clear to me that if we are serious about improving quality and access for patients, we have to address the concerns of providers on the front lines. One specific issue around burden that came up is the amount of time it takes to document information in patient charts in order to bill Medicare for patient visits. E&M visits make up around 40% of all Medicare payments under physician fee schedule, and guidelines have not been updated since 1997. Close to 750,000 clinicians use these codes, so CMS's policies have tremendous impact across many types of practices all across America. The current system includes 5 levels for E&M office visits. Level 1 is primarily used by non-physician practitioners, and physicians typically use levels 2 through 5. Doctors have to justify the level of E&M code that they bill by documenting specific types of information in the patient's chart. The requirements often mean that doctors have to cut and paste chunks of information across medical records strictly for billing purposes. Putting together notes to meet all of these documentation requirements takes up significant time and energy. This is a poor use of their time, and we are not leveraging the value of Americans' clinicians. This exercise of inputting text just for billing purposes packs the medical records with information that isn't useful for patient care. And time spent at the computer documenting and coding for visits is time doctors could be spending with their patients. Because of this, last week, we proposed historic changes to modernize Medicare and restore the doctor-patient relationship. We are proposing to streamline the system of office E&M codes and reduce the requirements for documentation. This proposal alone is one of the most significant reductions in provider burden ever taken by any administration. And the overall impact is significant. We estimate that this proposal would save approximately 51 hours of clinic time per clinician per year. So if you add up the amount of time saved for clinicians across America in 1 year from our proposal, it would come to more than 500 years of additional time available for patient care. That's huge. One thing that many people might not know is that CMS has a lot of practicing physicians, and they were a vital part of creating this proposal, because I believe it's important to hear from providers on the front lines when making policy that's going to affect them. I've gathered some of them to talk to you about this bold proposal because we want to make sure that everyone understands what we are proposing to do so that you can work with us and give us your comments to help make the final rule something that will have a positive impact on our healthcare delivery system. I want to thank those of you that have submitted questions to us, and we will try to answer as many as we can during the short time we have with you today. I want to remind everyone again that this is a proposal and we are currently in the 60-day comment period, so please send us your comments and suggestions. At the end of this webcast, we will let you know how you can get more information on this proposed rule that, when finalized, would take effect in 2019. And now I will pass it over to CMS Chief Medical Officer, Dr. Kate Goodrich, to introduce our panel and take your questions. Thank you.
Thank you, Seema. I'd like to introduce to you all our distinguished panel for today. We have Dr. Don Rucker, who is the National Coordinator for Health Information Technology, Dr. Anand Shah, who is the Center for Medicare and Medicaid Innovation Chief Medical Officer, and Dr. Tom Mason, who is the Chief Medical Officer for the Office of the National Coordinator. I'd like each of you to tell us a little bit about yourselves and your background.
Yep, so Don Rucker. I've spent 30 years trained as an internist and have practiced emergency medicine over that time. I'm intimately familiar with E&M documentation, having lived before the current rules and through the current rules.
I'm Anand Shah from CMS. I trained in radiation oncology. I'm an attending radiation oncologist at the National Institutes of Health, where I specialize in treating patients with genitourinary malignancies. I'm also an oncologist at the FDA, as well as an adjunct senior fellow at the Leonard Davis Institute of Health Economics.
I'm Dr. Tom Mason. I also trained internal medicine. Prior to joining ONC, I spent 15 years in the primary care setting in the Cook County Health and Hospital System in Chicago, Illinois.
Great. And I'm Dr. Kate Goodrich, Chief Medical Officer at CMS. I am an internist and hospitalist practicing here in the DC area, and I am very familiar with our documentation requirements, so I know it personally. So what I want to do first to kick it off is turn it over to you, Don. Maybe you can give us a little bit of background about how we got where we are today and what is the problem that we're trying to solve.
Sure, Kate, yeah. So we've been dealing as a country with how to pay doctors for office visits for a long time, my entire career. So when we did this in the late 80s, we had problems with it. The 1995 E&M codes with the 97 modification were really an effort to balance two conflicting things, which is one, to pay doctors appropriately for the care they were providing, yet not bankrupt Medicare. So how do you put those two things together? The way the problem was solved in 1995 was to require a lot of documentation text. And for docs watching this, this is a very medical school type of text, a lot of very medical student type of questions, review of systems, physical exam. It may not have made sense then, but certainly in an era of electronic medical records, we've heard from everybody, this is just not working. What the system is sort of doing now are big templated notes, a lot of note bloat. It takes a lot of time to do this work. We just heard 51 hours. I don't know, at least in my practice, I'm sure it has taken me more than 51 hours a year to do. I think it's a good bit more than that. And it's not just putting the note together. You actually have to read these notes. If you're practicing with a lot of colleagues, trying to sort through and find real non-templated data is very hard. It generates safety issues for patients because the real clinical data is often hidden in all of the billing boilerplate. And finally, as somebody who's been involved in educating medical students and residents, it really has distorted our education system for medical trainees. The students can't really write real notes because they're trapped in this. The residents, I think, often spend more time worrying about the documentation than they do the patient. So a lot of issues. How does this actually work out for the patients? Patients see this in a couple different ways. So patients see it, the doctor's looking at the computer and not at them, right? So we've heard that complaint time and time again, both at Office of the National Coordinator and certainly many folks at CMS. Patients ultimately, all of this text then is handled by coding and billing specialists. There's a lot of money spent on that. It's a couple % of the entire spend is spent in this billing rework. Patients pay for that. The American public pays for that. It's not a freebie. And finally, the last thing I think that's very interesting in our modern app world, CMS and ONC are working on a lot of interoperability rules. And we, in the next couple of years, are going to have your electronic records available to everybody in the country on their smartphone. And we want those notes to reflect the care that you received and not just billing text boilerplate that is a head scratcher. So this proposal, and we'll invite the comments, is, we think, going to be profound.
Great, thanks, Don. So I want to tell you a little bit about the proposal that we are making. So as Seema mentioned, and as you've mentioned, Don, the current system includes 5 levels for evaluation and management office visits. Level 1 is mainly used by non-physician practitioners, whereas physicians, but also nurse practitioners and physician assistants, primarily use levels 2 through 5. And the differences between levels 2 through 5 are often really difficult to discern and time-consuming to document. So I know when I'm practicing and I'm seeing, let's say, a complex patient who I think maybe is level 3, 4, or 5, I have to decide which level. And then once I've decided that, I have to go back and remember how many review of systems I need to document for, say, level 4, how many organ systems in the physical exam I have to document for level 3 versus 4 versus 5. I have to re-document often the past medical history, the family history, the social history, when, by the way, one of my nurses or a medical student may have already documented that, or it was previously documented on a previous visit, and I have to re-document all of that. So that's how you get to the 51 hours or more, right? So what we've done is we have proposed to move to a system with minimal documentation requirements for levels 2 through 5 and 1 single payment rate. So essentially we've collapsed the codes between 2 and 5. 1 payment rate for any of those levels, and the requirement is that clinicians would need to document what is currently associated with level 2, so that minimum level 2, which then really allows them to focus their documentation on what is most important for the patient in front of them, really focusing on that medical decision making. And by the way, if the chart already has in it their past medical history, their family history, their social history, or somebody else has documented that, you now would not have to re-document that. So this proposal really tries hard to remove the redundancy that is in place right now in the current system and get rid of many of those superfluous requirements that just don't make sense for patient care. So again, we believe that this will allow clinicians to spend much more time with their patients, less time doing paperwork, by the way, at night and on the weekends oftentimes. I know that personally. And of course, it will allow clinicians to spend less time combing through these lengthy and bloated notes in order to find important clinical information. So what I'd like to do now is move to questions that were submitted to us through email and through Twitter. And we'll try to get to as many as we can today. And thank you all for submitting your questions. The first question I'm going to pass over to you, Anand. This is from Dr. Lloyd Miner, who is Dean of the Stanford University School of Medicine. And he says, one concern is that CMS's proposal will lower reimbursement for physicians performing level 4 and level 5 care, impacting those who disproportionately see patients with complex care needs. Can you elaborate on how CMS went about assessing the impact of our proposal on clinician reimbursement, particularly for practices seeing complex patients?
Okay, we appreciate Dr. Miner's question and concern, and it is certainly one that we are exquisitely mindful of. Medical decision making is increasingly nuanced, and the therapies that we discuss with our patients are becoming much more complex. This is especially true in certain subspecialties such as cardiology and oncology. Providers spend time evaluating patients. They also spend time counseling families as well. So there tends to be a shift towards level 4 and level 5 documentation. That said, our internal impact analysis suggests at most an up or down of about 1 to 2%.
Excellent. And Dr. Miner has a second question I'd like to ask you, Don. So in addition, has CMS estimated the degree to which simplified coding could improve physician productivity? And if so, would productivity gains help to offset potential losses in reimbursement?
We think that the gains in time are going to be very large. It's important to note, as I think all docs know, this activity of this documentation goes on in almost every single note. So you save time in almost every single note. We think it's large. It varies by practice how much money is spent on billing. Each provider can, look at what they're spending on billing and coding. But certainly I would think 5%, 6% is probably the minimum. Right? A lot of that is in very labor-intensive review of the subtle nuances in the levels, Kate, that you pointed out. So we think that savings will accrue to patients and providers.
Absolutely. I think that's right. So the next question, Tom, I'd like to hand over to you.
Sure.
This was an anonymous question, but I know it's on the minds of a lot of practicing clinicians, which
Sure.
is, what effect do you think that this proposal will have on electronic health records and their usability?
Well, I think if this proposed rule is finalized, it will have a significant impact on EHRs and usability. As Administrator Verma mentioned, both CMS and ONC really sought out comments from the clinical community about what are the burdens associated with electronic health records. And in a recent listening session, the American College of Physicians actually said that documentation burdens are the #1 usability challenge with electronic health records. And I really think a lot of the proposed rule, specifically decreasing the documentation requirements down to minimal level 2, will have a significant impact in improving the effectiveness, the efficiency of electronic health records. It will allow for innovation and improved data analytics. It will allow for more of a focus on patient engagement and really focusing on how to leverage the capacity and the functionality of health IT to improve patient-centered care. So I think there's a substantial amount of usability impact that these proposed changes will have on electronic health records.
Yep, couldn't agree more. The next question, also anonymous, I will actually answer, and this is, how often will I need to verify and or update clinical content in the record but not in my encounter note? So one of the things that I think is most exciting about this proposal is the fact that what we are proposing is that clinicians would not have to re-document what is already in the medical record when the patient comes in for a follow-up visit or some other encounter. So they would really only have to update any new information if they had any new problems that were not previously documented, or if there were any new physical findings or new aspects to their family's medical history. So again, this proposal really does try to remove a lot of the redundancy that I know we have all felt in our time practicing documenting when patients come in to visit. The next question, Anand, I want to turn over to you. This also anonymous. What impact do you think that this proposal will have on the healthcare delivery system outside of just Medicare? Do you expect that private plans will follow suit and reduce documentation requirements in a similar way?
Well, Kate, as the administrator mentioned, our proposal is transformational in terms of medical documentation and how providers take care of their patients. We anticipate that, as in the past, many commercial payers will opt to follow. We certainly welcome and solicit feedback from private payers regarding our proposal, and we look forward to receiving those comments.
Great. Yep. Thank you. And Don, just two more questions. Don, this one I think is really great for you. This is from Michael Warner from Patient Advocacy Initiatives. And what he asks is, in light of technology's thirst for data to identify best practices and construct predictive algorithms, is it possible that eliminating or making optional history and examination documentation requirements will undermine patient care and big data efforts?
We think it's actually going to be the exact reverse. So as somebody who also, besides practicing, has trained and done a lot of computer science, one of the problems in computer science doing natural language analysis of notes is actually sorting out the vast amount of templated text in there that really is almost antimatter of information, right? It's you know, a classic signal to noise problem for anybody with a engineering mindset. Taking that clutter out, the same way it helps the docs in terms of understanding what's wrong with the patient and speeding them up, it actually helps computers that don't have to then sort through this. So we think this is actually going to be very powerful for some of the modern science tools that are going to allow us to use electronic records we've invested so much in and to actually figure out algorithms to improve care. So it's a win even on these second order things, not just the simple time and pain and suffering.
Exactly. So our last question is a two-part question, and I will take the liberty of answering these. The first is, are you concerned that physician practices that report a level 4 or 5 E&M service but document only to level 2 will be out of coding compliance and subject to audits and denials? So based upon what we have proposed that clinicians will only have to document to the current level 2 requirements, even if they are seeing patients at a level 4 or 5. And what this really does allow them to do is to focus their documentation on the most important part of that visit, which typically is the medical decision making, but may include other components as well. We are very much, again, looking forward to public comments on any unintended consequences that this may have related to program integrity. So very much want to hear from folks for that. And the other part of this question, and by the way, this is from Richard Scott, I forgot to mention, is which, if any, of the E&M payment and documentation proposals do you expect to implement on January 1st, 2019? So again, we take very, very seriously the public comments that we received. Don, you told me you used to write some of the letters to CMS back before you were here. And as Don and Anand and Tom know, we read all of these public comments. We do not skip a single one. It is critical to us to get your comments in order to have the best final rule that really does reduce burden on clinicians and really, I think, foster that patient-clinician relationship. So please do send us in your comments. So that ends our live panel. I want to thank my fellow panelists as well as those of you watching online. I apologize if we didn't get to your question. Some of you sent questions that were very technical in nature, and we want to be able to answer them. So I want to remind you that CMS will be hosting an open door forum tomorrow, July 19th, from 2 to 3 p.m. Eastern Time, where subject matter experts will be on hand to answer any technical questions about how this rule could be applied. I also want to again remind everyone that we are still in the public comment period on this proposed rule, and comments provided in this forum do not replace the public comment process. So please submit public comments on the proposed rule by September 10th, 2018, and visit go.cms.gov/patientsoverpaperwork for more information on this and many other ways CMS is putting patients over paperwork. Thank you.